and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Van Morris from MD Anderson Cancer Center, co-chair on systemic therapy for stage 1 to 3 anal squamous cell carcinoma, ASCO Guideline. Thank you for being here today, Dr. Morris.
Thank you for having me. On behalf of our committee who put together the guidelines, I'm really excited to be here and talk with you today.
Great. Then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Morris, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to jump into the content of this guideline, Dr. Morris, can you provide an overview of both the purpose and the scope of this guideline on stage 1 to 3 anal squamous cell carcinoma?
So anal cancer is considered a rare malignancy for patients in the United States and across the world as well. Even though it's not something we see as commonly, for example, as the adjacent colorectal cancer, this still is a cancer that is rising in incidence every year in the United States. And really, despite the presence of the preventative HPV vaccines, which we hope will ultimately prevent and eradicate this cancer, we still expect the incidence to continue to rise in the coming decades before we really start seeing numbers begin to decrease as a result of the vaccine. So this is an alarming trend for which oncologists will continue to see likely more and more cases and new diagnoses every year. So we wanted to review the most recent literature and provide oncologists up-to-date recommendations for how they can best take care of patients with a new diagnosis of localized anal cancer.
Absolutely. I appreciate that background and context to set the stage for this guideline. So then next, I'd like to review the key recommendations of this guideline. So starting from the first clinical question, what are the recommended radiosensitizing doublet or single chemotherapy agents for patients with stage 1 to 3 anal cancer?
It's true that really the standard treatment for patients with localized anal cancer has not changed over the last literally half century when the NIGRO regimen was first reported back in 1974, 50 years ago. The standard of care for patients with a new diagnosis of localized anal cancer, centers around concurrent chemotherapy and radiotherapy. And we looked at the various randomized controlled trials and the highest level of evidence which has been reported over the past decades. And really, for most patients, the standard of care continues to remain doublet cytotoxic chemotherapy in combination with radiation. We reported that the most commonly, and I think most accepted regimen here is a combination regimen of 5-FU, intravenous 5-fluorouracil, with mitomycin C. And this most commonly is given on a week 1 to 5 regimen. The 5-FU, we recommended a dose of 1,000 milligrams per meter squared per day on days 1 to 4, and then on days 29 to 32 of the radiation treatment. And then the mitomycin C, looking at various trials, has been given at a dose of 10 milligrams per meter squared on day 1 and day 29, or alternatively, a single dose of mitomycin C at 12 milligrams per meter squared on day 1. I think that the thing it's important for clinicians and patients alike to remember is that this chemotherapy can be very toxic in patients who are undergoing a curative intent therapy for this diagnosis of localized anal cancer. I think it's just important for oncologists to be watching closely the blood counts for the patients to make sure that the myelosuppression doesn't get too bad. And then in select cases, if that is the case, when the oncologist opts to go for the day 1 and day 29 dosing, it may be prudent, if the myelosuppression is too excessive, to consider withholding that day 29 dose.
Great. Thank you for providing those recommendations, along with some of those dosing and the schedule recommendations from the expert panel. So are there any other alternate dose or schedule recommendations from the expert panel?
Yeah, but I think that we saw with the ACT2 data, that was a randomized trial that was done out of the UK. that compared 5-FU mitomycin with 5-FU cisplatin as two different doublet cytotoxic regimens, that overall outcomes were very similar between the two regimens in terms of curative outcomes for patients treated, whether 5-FU mitomycin or 5-FU cisplatin. So certainly there is evidence supporting the use of cisplatin as a second cytotoxic agent with 5-fluorouracil. In the ACT2 study, that was given at a dose of 60 milligrams per meter squared on days 1 and 29, along with the 5-FU at the regimen I talked about previously. There is other lower level of evidence data suggesting that even the 5-FU and cisplatin can be given on a weekly schedule and that can be safe. Actually, at my institution at MD Anderson, that is our standard practice pattern as well. There's also the option when we're thinking about giving pelvic radiation for patients with lower GI cancers. Many oncologists in the treatment of localized rectal adenocarcinoma are accustomed to using capecitabine as a chemosensitizer in patients with localized rectal cancer. If I'm giving chemoradiation for a patient with localized anal cancer, can I substitute the intravenous 5-FU with oral capecitabine? And although the evidence is not as strong in terms of available data with regards to randomized controlled trials, there certainly is data that suggests that capecitabine may be an acceptable alternative in lieu of intravenous 5-fluorouracil. That would be given at a dose of 825 milligrams per meter squared on days of radiation. But certainly, I think that that's a feasible approach as well, and maybe even associated with less hematologic toxicity than intravenous 5-FU would be.
Great. It's important to understand all the options that are out there for patients with early stage anal squamous cell carcinoma. So in addition to those chemoradiation recommendations, what is recommended from the expert panel regarding induction chemotherapy or ongoing adjuvant chemotherapy for this patient population?
When we think about treating patients with lower GI cancers with curative intent therapies, when we think about the more common rectal adenocarcinoma, oncologists may be used to giving chemoradiation followed by subsequent cytotoxic chemotherapy. But actually, when you look at the data for anal cancer, really there's not any data that strongly supports the use of either induction chemotherapy prior to chemoradiation or adjuvant post-chemoradiation chemotherapy. The RTOG 9811 study was a trial which evaluated the role of induction 5-fluorouracil prior to chemoradiation and did not show any survival benefit or improved outcomes with the use of induction chemotherapy in a randomized control trial setting. The ACT2 trial, which I referenced earlier, that was a 2x2 design where patients were either randomized to concurrent chemoradiation with 5-FU mitomycin C or concurrent chemoradiation with 5-FU cisplatin. But then there was a second randomization after chemoradiation where half of the study participants received adjuvant cisplatin 5-fluorouracil after completion of their chemoradiation, or the other half who were randomized to the standard of care, which of course would be observation. And what that trial showed was that there was no added benefit with the addition of post-chemoradiation cytotoxic chemotherapy. So we look at these data and that say that in general, for the general population of patients with localized stages 1 to 3 anal cancer, there really is no supporting data suggesting benefit of either induction chemotherapy or adjuvant chemotherapy. And to that end, really, it's concurrent chemoradiation remains the standard of care at this time for patients with a new diagnosis of localized anal cancer.
Absolutely. It's just as important to know what is not recommended as it is to know what is recommended for these patients. And so I thank you for explaining the evidence behind that decision from the panel as well. So then are there any other considerations for special populations that oncologists should consider?
I think so. I think that anal cancer is a disease where we don't see that many patients being diagnosed earlier at a younger age, especially in relation to the alarming trend of early onset colorectal cancer that we're currently seeing right now. So there may be patients who come with a new diagnosis of localized anal cancer who are an octogenarian at an advanced age or may have other significant medical comorbidities. And if that is the case, we get called about this quite frequently from outside institutions. I have an 85-year-old who is coming to my clinic with this diagnosis. I don't feel comfortable giving this patient doublet cytotoxics? What options do I have, especially given other organ dysfunction that may precede this diagnosis? And I think that in that case, there are times when it's okay safely to drop the mitomycin C and opt for single agent 5-fluorouracil as a single cytotoxic agent. So I think that that would be something that we've certainly incorporated into our practice at our institution. There's also an association between various autoimmune disorders, patients on immunosuppression, even persons living with HIV being at higher risk for this virally associated cancer. So I think that, again, if the patient is coming with baseline immunosuppression for these reasons prior to treatment, certainly kind of being in tune to the potential for hematologic toxicity and watching these patients very closely as they're getting chemoradiation remains really important.
Definitely. So you've just discussed some of those comorbidities and patient characteristics that are important for clinicians to consider when deciding which regimens to offer. So in addition to those, in your view, what is the importance of this guideline and how will it impact clinical practice for clinicians who are reading this guideline?
Chemoradiation remains a very effective option, and most patients will be cured with this diagnosis and with this treatment. So it's important to make sure that these patients are able to safely get through their treatment, minimizing treatment delays due to toxicities which may come about because of the treatment, and really help to carry them over the finish line so that they have the best likelihood for achieving cure. So we really hope that these data will provide oncologists with a readily available summary of the existing data that they can refer to, and continuing to help as many patients as possible achieve and experience a cure.
Absolutely. So then to build on that, it's great to have this first guideline from ASCO on anal squamous cell carcinoma, but how will these new recommendations affect patients with stage 1 to 3 anal cancer?
I certainly hope it will allow patients and oncologists to know what their options are. It certainly is not a one-size-fits-all treatment approach with regards to the options which are available. Depending on the patient, depending on the various medical conditions that may accompany them, these treatments may need to be tailored to most safely get them through their treatment.
I appreciate you describing the importance of this guideline for both clinicians and patients. So what other outstanding questions and future research do you anticipate seeing in this field?
It's a really good question, and I think that there is a lot coming on the horizon. Even though the standard treatment has really not changed over the last half century, I think it's still remains true that not all patients will achieve cure with a chemoradiation treatment. So a recent trial has completed enrollment in the United States. This is the EA 2165 trial led by one of our committee members, Dr. Rajdev, and Dr. Ang as well, that's looking at the use of nivolumab anti-PD-1 immunotherapy after completion of concurrent chemoradiation. So in that trial, patients were randomized to concurrent chemoradiation followed by either observation or 6 months of adjuvant anti-PD-1 therapy. We're really awaiting the results of that. Hopefully, if we see an improvement with the addition of nivolumab following concurrent chemoradiation, our hope would be that more patients would be able to achieve cure. So we're certainly looking forward to the outcomes of that EA 2165 study. And then I think one question that we often get from our patients in the clinics is, what is the role of circulating tumor DNA in the management of my disease? And really to date, there have been some series which have shown that we can assess patients for circulating tumor DNA after completion of their concurrent chemoradiation. That may need to start about 3 months after to give time for the radiation to wear off and most accurately prognosticate that. But I think that this will be a powerful tool moving forward, hopefully not only in the surveillance to identify patients who may be at high risk for recurrence, but ultimately to translate that into next generation clinical trials, which would treat patients at higher risk for recurrence by virtue of a detectable circulating tumor DNA result. In doing so, hopefully cure even more patients with this diagnosis.
Yes, we'll look forward to these developments and hope to add more options for potential treatment and surveillance for patients with anal cancer. So I want to thank you so much for your work to develop these guidelines and share these recommendations with us, and everything that the expert panel did to put this guideline together. Thank you for your time today, Dr. Morris.
Thank you. And thank you to ASCO for helping to keep this information out there and ready for oncologists for this rare cancer.
Absolutely. And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/gastrointestinal-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.